The objectives of this module are first to discuss the biopsychosocial model of pain, and then to describe cognitive behavioral treatment strategies for chronic pain management. The biopsychosocial model of pain highlights opportunities for non-pharmacological management of pain. Dr. Fillingham, a distinguished professor and director of the University of Florida Pain Research and Intervention Center of Excellence, notes, "Awareness of individual differences in pain in the clinical setting is critical." He continues, "Unfortunately, the time and resource constraints that characterize most current healthcare environments conspire against this approach, which requires a level of time and expertise that is typically available only in the context of a multidisciplinary treatment team." For the non-pharmacological management of acute pain, the Joint Commission requires accredited hospitals and facilities to provide non-pharmacological therapies for acute pain. Those therapies that have received support include acupuncture, cognitive behavior therapy, or CBT, chiropractic therapy, electrical stimulation, exercise, massage therapy, osteopathic manipulative movement, physical therapy, or PT, and relaxation. The American College of Physicians recommends that non-pharmacologic therapies be considered first-line options for chronic low back pain. Those therapies that have received support include acceptance and commitment therapy, or ACT, which is a type of cognitive behavioral therapy, acupuncture, biofeedback, CBT, manual therapy, massage therapy, mindfulness-based stress reduction, relaxation, spinal manipulation, Tai Chi, and yoga. For the remainder of this presentation, I'll be focusing specifically on CBT for pain. This is an evidence-based, non-pharmacological intervention that targets a variety of psychological factors that are known to influence pain outcomes, including something called pain catastrophizing. Now, the primary goal of CBT is to promote an active approach to coping with chronic pain. I will briefly outline one effective CBT approach for chronic pain, developed by John Otis. On the right of the screen, you will see a therapist's guide, and below it, a link to helpful worksheets from the manual. Otis includes this description of the pain cycle in his book. When pain persists over time, you may develop negative beliefs about your pain. For example, "This is never going to get better," "I can't cope with my pain," or negative thoughts about yourself. For example, "I'm worthless to my family because I can't work," "I'm never going to recover." As pain continues, you may avoid doing activities, such as things at work or social activities or hobbies, for fear of further injury or increases in pain. As you withdraw and become less active, your muscles may become weaker, you may begin to gain or lose weight, and your overall physical conditioning may decline. This diagram here shows how distress and disability feed back into pain and make it seem worse. There are a number of key components to CBT. The first is cognitive restructuring. This involves teaching patients how to become more aware of their so-called automatic thoughts in situations where they experience elevated pain, and in monitoring their thoughts to recognize patterns that may include unhelpful interpretations of events or sensations. Cognitive errors such as all or none thinking, or mind reading, or catastrophic thinking. Once patients are able to observe and identify these patterns, they can then use strategies to adopt more adaptive or helpful thoughts related to pain. In a minute, I'll give you an example of how that might be done. A second component is relaxation training, and this is critical for reducing stress levels and reducing muscle tension, which are each related to pain. This includes strategies such as diaphragmatic breathing or deep breathing, visual imagery, and progressive muscle relaxation. A third component is time-based activity pacing, teaching patients to be more active without overdoing it. One pattern that is observed in chronic pain patients is that they may initially try not to do anything at all, and then maybe they try to overdo something, to do it the same way they used to before the pain. And this can increase pain and ultimately lead to greater efforts to avoid this activity in the future. You want to make sure that patients are engaging in an appropriate level of an activity. A final component includes graded homework assignments. Much of the work in CBT is done between sessions by patients. This includes helping patients to decrease activity avoidance, to disrupt that cycle, and also to reinforce healthy, more active lifestyle choices. The CBT approach to chronic pain treatment can be understood in terms of gait control theory. For a brief review of that theory, please see the Multidisciplinary Pain Management course module. The gait mechanism in the dorsal horn of the spinal cord modulates pain signals by either opening or closing. This opening or closing is influenced by descending neural impulses from the brain and is referred to as descending pain inhibition or pain facilitation. In the physical domain, degenerative changes, muscle tension, and drug abuse can open the gait and increase perceived pain intensity. On the other hand, drugs, surgery, and reduced muscular tension can close the gait. That's where strategies such as progressive muscle relaxation may come into play. In the cognitive domain, paying attention to pain, having thoughts that pain is beyond your control or that pain is a terrible thing, these are things that can open the gate. On the other hand, distraction, thoughts that pain is controllable, beliefs that pain is predictable and manageable can close the gate, and those are targets of CBT. Emotions such as depressed mood, anxiety, fear, and anger can open the gate, whereas emotional stability, feelings of relaxation, calm, and positive mood can all close the gate. Too much or too little activity, having an unhealthy diet or work-life balance can all open the gate and increase perceptions of pain intensity. However, appropriate pacing, healthy habits, and work-life balance can close the gate. Finally, having little social support or having others who focus on your pain or worry about your pain can increase the intensity of pain. On the other hand, having strong social support and encouragement from others can be beneficial for pain management. One useful strategy for CBT in general is known as the ABCs, or activating event, beliefs, and consequences. This approach can be applied to chronic pain, as seen here in this slide. Here, the activating event might be waking up in the middle of the night in pain. For this individual, waking up led to certain interpretations of their experience. They might have thought, I can't take this is terrible, my whole day is going to be ruined tomorrow. These are thoughts that could be labeled as pain catastrophizing. Their reactions to these thoughts could be feelings of sadness, physical sensations such as sweating or headache, and their behavioral reactions may include watching TV for the rest of the night and going in late to work in the morning. We can see here how patterns of unhelpful thinking can lead to behaviors that can increase risk for pain or worsen functioning. Here are some useful resources on CBT for chronic pain, including a case study by Heapy and colleagues that I will present next. Jack is a 57-year-old African-American male who was recently separated. He's a freelance writer working up to 80 hours per week. His low back pain started 10 years ago following a motor vehicle accident that resulted in spinal stenosis and disc herniation. At the first session, Jack rated his pain as an 8 on a scale of 0 to 10, with 0 being no pain at all and 10 being the worst pain imaginable. Jack does not wish to take narcotics because of his fear of addiction. He reported taking over-the-counter medications and using hot showers to manage pain. He stated that standing, twisting, and prolonged walking will make the pain worse. He's aware of a pattern where decreased activity leads to weight gain and ultimately worsens pain. Jack has tried different treatments. He noted that chiropractic therapy, massage therapy, and acupuncture have all provided temporary pain relief in the past. The case formulation includes a number of factors that aggravate Jack's pain. These include him expecting perfect pain coping, his anticipation that he should be able to control his pain completely. He has difficulty asking others for help when he is experiencing pain. He also noticed that reducing physical activity and increasing social isolation may make his depression worse, which in turn can increase pain and worsen functioning. His perfectionism also leads to long work hours, which increase fatigue and decreases opportunities and motivation for pleasurable activities. These are things that might be helpful for pain management. In terms of strengths, he does seem motivated to engage in self-management. He's intelligent, he's expressive, and he has an ability to maintain a demanding work life despite pain. There are a number of signs here that bode well for treatment. Jack's treatment involved 4 components that were delivered over 10 sessions. There was relaxation and exercise, which involved walking for enjoyment as well as exercise without specific time or distance goals. Cognitive control, addressing Jack's tendency to minimize his coping efforts and to criticize himself for not functioning as well as someone without pain. And task persistence. His goals were to increase treadmill walking to 45 minutes per day, to complete tasks more consistently, to leave the house for leisure activities at least once per week, and to engage in hobbies at least 4 hours per week. So how did treatment work for Jack? By the end of treatment, Jack was highly satisfied. He believed that treatment had improved the quality of his life. He was able to completely achieve his first 2 goals with 50% achievement of his second 2 goals. His depression severity rating decreased by 4 points on an objective rating scale, which was clinically meaningful. He was able to increase use of 6 out of 8 coping strategies. The degree to which pain interfered with his daily activities decreased by 0.6 points on an objective rating scale, and this again was clinically significant. Notably, his pain intensity did not change. Despite this, Jack reported improved functioning in different areas of his life, and this highlights the importance of assessing multiple domains of the pain experience, including intensity, interference, and overall quality of life. Here are some additional resources, including reviews of psychological treatments for pain. In addition, there are a number of course modules with information directly relevant to non-pharmacological management of chronic pain.